Welcome, everyone. Thank you so much for being here today. So, today is week 3 of our 4-part series in partnership with OMPRN. So, OMPRN is the Ontario Molecular Pathology Research Network, and we're very excited to bring you to week 3 of this installment. So, today's webinar topic is reading and understanding your clinical report. So, I'm going to pass it over to Kester, one of the leads at OMPRN, to introduce our speaker for today.
Alrighty, thank you, Vanitha, and good afternoon, everyone. I am pleased to introduce Dr. Tracy Stockley to guide us through this important and often complex topic about reading and understanding your clinical report. So Dr. Stockley is a molecular geneticist, which means that she's an expert in understanding how changes in our genes can lead to diseases like cancer. She's the former head of clinical laboratory genetics at the University Health Network in Toronto. And at UHN, she helps oversee genetic testing for cancer patients. Some of the work that she does involves the development of new tests to look for important genetic clues called biomarkers that can guide cancer care. She is deeply involved in making sure that these complex genetic tests are all done accurately and safely. Tracy works with national and international organizations like Health Canada and the College of American Pathologists to help set high standards and ensure quality in lab testing here in Canada and around the world. Tracy is also a cancer survivor, and her experience has further deepened her commitment to patient support and engagement in research. I have been very lucky to work with Tracy since I first joined OMPRN in 2019. She's always been a strong supporter of OMPRN's research and education programs, and OMPRN is a much better network for her involvement in it. So I am thrilled to have her here with us today to help demystify clinical reports and empower patients to better understand their health information. Please join me, everyone, in welcoming Dr. Tracy Stockley.
Thank you very much for that nice introduction. Just pull up my slides. The slides look okay on your side? Okay, perfect. Yeah, so thank you very much. As Kester said, I'm really here to kind of help you read and understand your clinical report. And I think particularly, having had a cancer experience, there's a lot of interactions with the medical team you go through. And I think, however much more informed you can be about some of those parts really can help you when you're discussing things with your team. So that's what I really called as my subtext here, really helping you understand your pathology lab report so that you can discuss things more in depth with your healthcare team. So if you saw some of the parts of the first 2 seminars, they did go through a lot of these parts, just what is pathology and what are some of the tissues that we examine. But I'll just kind of give a little overview here. So when we talk about molecular pathology testing, it really is in some way examining the tissue that we're taking from cancer patients. So in this little picture that I show here, if you're a patient with a lung cancer, your clinical team will want to get a sample of your tumor so that they can have the pathologist examine it. And that can be done in different ways. The most common ways are taking a tumor biopsy. So usually a needle is placed in, often under visual imaging guidance, and taken a sample taken. And then other times you might have a surgery where they take out a much larger piece of the tumor, where they're trying to remove it all or trying to remove some larger piece of it. And in both those cases, that gets sent to the pathology department, where the tissues are processed, and the pathologists then do a number of different investigations on that tissue and try to help your clinical team make some important decisions about that. And then at the right-hand side, you can see all of the things that can be decided based on that pathology investigation. What's the stage of your cancer? Should we do some genetic testing? What surgery and other types of therapy do you need? So really, the pathology has a very key and central role in the cancer diagnosis, prognosis, and treatment decisions. And the biomarker testing that I'll talk about can really help then guide personalized treatment, particularly for your type of cancer, for all the changes that we see in that tumor. So I mentioned these terms. I thought I would just go through them again because it's important. When we're testing tumor tissue, we're often looking for slightly different things depending on the type of tumor and the stage that it's at. So diagnostic testing really is trying to say, is a disease there or not? And so in terms of cancer, the question we're trying to answer is what type of cancer is present and what stage is it at? Prognostic just means information about how likely your disease is to progress or what an outcome might be. So again, in terms of cancer, what's the course of the cancer likely to be? Is it a very aggressive cancer, or is it some a cancer type that's a little more slow growing? Because that again really dictates how your team will approach your treatment. Predictive test is really trying to say whether or not you would respond to a treatment or therapy. So how likely is it that this particular treatment will be effective for my cancer? And then there's also, we also test for therapeutic reasons, which is typically means that you're monitoring and predicting the effect of the treatment. So if someone is undergoing treatment, how well is that working for the patient? Do we see changes in the tumor over time because of the treatment that we are giving at that point? So then pathology samples and the testing. So I mentioned this before, the same idea, the tumor biopsy. So these, of course, you can imagine because they're typically taken with needles, they can be very small. So sometimes there's a limited amount of testing you can do on a biopsy. So occasionally patients may have to go for more than one biopsy, excuse me, in order to get enough tissue. Tumor resections, which are larger and from surgery, typically we have a lot more opportunity to do more testing on that just because there is more tissue to work with. And then in the bottom three slides, three images that I show there, what happens to that tumor tissue when it's taken out is that it actually is processed into something we call a block. So the tissue is embedded in it's fixed and then embedded in a paraffin wax, and then sections of that tissue can be made. Sorry, just getting over a cold. And then the testing that we do really is specific for each cancer type and stage. And sometimes we'll be doing immunohistochemistry staining of tissue samples on the slides. And then other times we will be scraping the tissue off of those slides in order to extract DNA and RNA to do genetic testing. So I won't talk too much about immunohistochemistry, but I did want to just briefly mention it because it will show up in a large number of pathology reports you might be looking at. So immunohistochemistry testing is done on the tissue as it's laying on the slide, because part of the information you want to get is it's a stain of the cells on there, but what you really want to know is to have a look at the structure of the cells as they lay on that tissue and stain only certain parts of it. So it's really trying to maintain that tissue and cell structure as you look at the stains. And it's really looking at very specific proteins in different cancers to see if they're present or not, or if they're at higher levels or not. So I think you can appreciate in those images I show there at the side, this is one of the markers that's very commonly tested. And as you get to where it says HER2 3+, that's more deeply stained than the HER2 0. So these are the kinds of assays that are done for IHC. And in your report, you will often see sometimes the abbreviation IHC or immunohistochemistry, and there might be a list of a number of different markers that they looked at in that testing. Okay, so then just kind of switching more, I think for most of the rest of my talk, I'll talk about the genetic testing on cancers. So why is this important? So it's really, genetics is really fundamental in cancer, because cancer is really driven by acquired changes that occur in our cells over time, particularly the adult onset cancers. So normal cells have a mechanism within them that tell them when they should stop growing. So when they touch up to another cell or they get to be a certain density, cells will say, okay, I'm going to stop growing. But what happens normally in our lifetime is that environmental exposures and even just natural aging, our cells acquire mutations. And eventually over time, if enough mutations are acquired and in the right types of genes, then the cell loses that ability to stop growing. And that's when you really can get uncontrolled growth, which becomes a tumor. So trying to detect these genetic changes that cause some of these processes is really fundamental to helping us understand and control cancer. And I know there's a lot of information on this slide, but just as a very quick sort of highlight of the kinds of things that we're looking at when we're doing genetic testing. So if you think about your cell, your genetic material is contained within there in chromosomes. So chromosomes, for some cancers, we really are looking at the number and structure of chromosomes. This is particularly for the blood cancers, leukemia or lymphoma. And because in those cases, a lot of times the chromosomes have swapped parts with other chromosomes or they're missing parts. So we can detect that most easily just by something called karyotype, where we're looking at number and structure of chromosomes. And then for a lot of the testing, especially some of the newer molecular testing that's been coming up over the last 5 to 10 years, we're drilling down further into the actual DNA. And when you look at DNA, you can see there I wrote, there's a list of the colored bases. So that's really what we're trying to look at when we look at DNA. We're trying to read through the known sequence that should be there in important genes and see if there's any changes that happen that are mutations. And then up at the top, we put the RNA and protein, just as a reminder that the real important part is, even if we see a change in the DNA, it's that it's affecting the protein. So somehow it's affecting the cell function, something the cell is doing, and that cell function is really what drugs are actually targeting, okay? So I know in the first couple of seminars, there were a number of questions about cell-free DNA testing. So I did want to touch on that and the difference of that versus tissue testing. So cell-free DNA testing, or what's called a liquid biopsy, is just trying to take advantage of a very interesting phenomenon, which is that, and the picture on the side, the red structure in the middle is actually a blood vessel. And what it's trying to show in that picture is that a blood vessel, of course, connects to all the tissues in our body. So it will connect to normal tissues, but it will also connect to tumor, any tumor that might be there. And just again, through the natural process of cell death, cells are giving off parts of their material back into the blood circulation. And so tumor cells will also do that. And so patients who have cancer, as their tumor cells are dying, they'll be releasing parts of the tumor into the blood circulation. And the use of cell-free DNA means you can take a blood sample, specifically pull out the part of that sample that contains DNA that's been released from dying cells, and test that to see if there's any genetic changes that are specific to cancers. So it's a very exciting and very interesting field, and many different applications, whether that be early detection, helping us monitor people as they're in treatment, or looking for recurrence. But there are some complicating factors in this that we're still trying to manage. And because of that, cell-free DNA, it's still, the clinical utility is still sort of under investigation. So some of the things that happen are not every tumor type will give off cell-free DNA to the same degree. So these are, it's called shedding, whether you're shedding cell-free DNA or not. And sometimes patients may have multiple tumors with different genetic changes. And so that also is a bit of a confounder when you're taking cell-free DNA. So because of that, we know, and it's well known, that the genetic variants you see in cell-free DNA don't always match what we see in tissue. Sometimes there are different variants, sometimes either ones in tissue, not in cell-free, or the opposite, not in tissue and in cell-free. So at this point, tissue samples really are the gold standard for genetic testing, especially at the time of diagnosis, when they're trying to establish what type of cancer it is and what treatments they will need. Cell-free DNA, though, really, I think, has a lot of utility right now if we can access tumor. So if you can't access tumor, then cell-free certainly is a great option. You can at least offer some kind of testing to patients. And sometimes also if a patient really is just too unwell to undergo biopsy, or otherwise just can't have tissue taken. And so right now in Ontario, this is being rolled out for the use, particularly in lung cancer. Okay, so I did want to point out two very helpful websites that can give you some information on some of the terms that you see in your reports. So this is the first one. It's called mypathologyreport.ca. So a Canadian website, and they really have a great glossary of any type of term you might see in your pathology report. So you can just type in their search bar a certain term you see, and it will give you a definition of that. They have a number of other things in there, including what they you can see on there called Ask a Pathologist. So if you have a particular question about some kind of test or something that is in your report, you can also do that. But it's very, very helpful site. And then the other very helpful site is, of course, the organizer of this series, the OMPRN. They have an amazing patient resources section with lots of great infographics and some video learning materials. So again, just a really great resource. So you can see on there some of the modules, but there's many more. Okay, so now I'll sort of get into some of the details of a clinical pathology report, and just try to every pathology report has a slight nuance depending on particularly on the hospital that might be doing the pathology. But in general, I'll try to go through some of the main sections that you will see. So, of course, like any medical information, there's going to be some of the identifiers that are on there. And usually somewhere at the top, there will be a list of specimens received. So if you think back to where I mentioned that we are taking tissue and putting them in putting them in paraffin wax. When we do that, those tissue specimens have to be very small. So because of that, if you've had a surgery, you will have many, many, many different paraffin blocks, paraffin embedded tissue bits that belong to you. So that's why you can see here, this patient had 7 different specimens. So those mean 7 different blocks that the pathologist has to look through. Sometimes if you've had a surgery and they've taken out lymph nodes, one of the blocks might be a lymph node. So there might be, many different things within those blocks. But, and I think sometimes that can be very confusing because you see this list of all these different parts, but that's really all it means. It just means that, there's a number of blocks that belong to you, and they've just had to make them small enough to be able to embed them and to look at them, okay? The other sort of highlight part on this report, they have put a sort of overall headline interpretation at the top. I think that's very helpful when labs do that, because rather than having to read through and piece it together through multiple pages, if you have something at the top, it's very helpful just to go first to there. So definitely on your report, look for that. Usually it's at the top. It will be some kind of thing saying an overall thing of the type of cancer, maybe something about staging, some of the results of the tests, things like that. The additional tests are usually much further down in your report. So the genetics or the IHC. And sometimes there might be other interpretation notes specific from the lab or the pathologist, and that might be further down. The reason for that is usually because the pathologist will do an initial review of the tissue, and then they might add on tests after. So they'll look at the tissue and say, I have to do IHC testing, I have to do genetic testing, and those get added or amended onto your report. So that's why it can have parts coming much later. The other very important part to look for is the diagnosis section. So this is really, you know, the nuts and bolts of what is the information on that tissue that the pathologist has seen. Sometimes it will have a header called synoptic diagnosis. That just means synoptic just means a more formal, regulated sort of format for the report. And it's just a standardized structure, and that is really done so that every report has the same components on it and nothing is missed. The diagnosis can also include a summary of the findings. So for solid tumors, that's things like the size, the grade, stage, whether it's invaded to the edge of the tissue they're looking at, which means it's larger and more advanced. Margins, meaning is there tumor at the edges of the tissue that they've taken? Again, just indicating whether it's more advanced or not. And the if there were any lymph nodes taken, it might also, you know, list in there any of the details of the lymph nodes that they saw if there was something, especially something related to the cancer. So the other thing that you'll almost always find, especially on your initial report at the time of diagnosis, is information about the type of cancer, of course, but also the stage. So there's a very commonly used staging system, because people, you know, obviously across many different hospital systems want to be able to share information on how advanced a person is at any one point. Then they've developed this staging system that everyone shares. So it's called the TNM system. T meaning tumor size, N meaning lymph node status, and M meaning metastases, whether it's spread to other tissues. And then in the middle column, you can just see this, the systems go from 0 to 4 for the tumor size, up to 3 for the lymph nodes, and then metastases is either 0, it hasn't spread, or M1, where it has. So as an example, if you look at your report and you see something like T3, N1, M0, so T3, if you know the system goes up to 4, you know that's definitely more advanced than, say, T0. And as an example, it might say in there stage T3, the tumor is invaded into adjacent tissues. And in this case, N1, so in the report, it might say something like N1, 1 to 3 lymph nodes are positive for the cancer, and then M0, no evidence of spread. Sometimes you might see the use of X, so TX, MX, or NX, and that's because they were not able to assess that part. So they can't measure it, or they don't have information about that. So it's sort of an unknown. They're, you know, ideally they're always trying to answer that question, but sometimes perhaps the tissue isn't sufficient, or you know, you haven't had enough imaging to determine if there's metastases. So sometimes it might say that. And really what that staging system that you'll see in your pathology report is trying to do is group you into one of these stages of cancer that you're probably very familiar with. So going from stage 0 to stage 4, with stage 4 being the most advanced. And the really important part about this that relates to biomarker testing is the testing that you get will very much depend on the cancer stage that you are at. So the testing, if you were a stage 3 colon cancer, is very different than you would get if you were, you know, stage 0. And so I think it's just important to keep that in mind too. Not everyone at every stage will have the same particular types of pathology testing done. It really does depend on the stage. And the reason for that is it's just, you know, you're really trying to do the test at the time that will be the most helpful for the patient at the point they are in their cancer. Okay, so I mentioned that sometimes you'll see the genetics added on to the pathology report as an additional or supplementary report. So I just copied a sort of example here. So if you're going down through your report and you see something like this, it might say supplementary report and then coming from molecular diagnostics. Sometimes it will be a complete other report in your chart. So it may, especially perhaps if it's been sent out and not incorporated into the pathology report. But a lot of times they do incorporate at least a sort of highlight of your genetic testing into your pathology report. Again, there'll be some details about what specimen was tested when it was done, the details of what. So here, for example, it's a lung cancer being tested and what the test was. So here, non-small cell lung cancer, next generation sequencing, which is just a type of DNA testing that we're using very frequently now. And then there'll be a result. Again, different labs report this differently, but in this case, something like positive, there was a KRAS gene variant detected. Usually this is followed by a great deal of method information. I think the most important part about the method information is just what genes were tested. We're always updating tests, and there's often new tests with more expanded gene lists. So it's good just to, you know, think about that when you get your tumor result. Well, what genes did they test, and how, you know, how comprehensive was that? Because in another year or two, you may want to go back and ask your doctor, are there new genes that are found in this cancer? What did I have last time? What should, you know, is there something new that I should be retested for? And then, so thinking again back to that, sorry, just go back one. So where I said positive KRAS variant detected. So if you keep looking down, you really somewhere will see this information. So here it's that KRAS gene again. And then what's shown across here are the actual change in the sequence of the DNA in the KRAS gene. So again, just reminding you with that little colored picture that what we're doing is reading the sequences of all those bases. So in the KRAS gene at a particular location of base 35, we see G change to T, and this has an effect on the protein, which is the next column. So at the amino acid site 12, glycine's been changed to valine. And then again, just going across, you can see that the lab has said this has a strong clinical significance. So meaning it's very important for your care. The oncologist should pay attention to this result. And the tier classification just really helps to highlight. Some patients, of course, will have many different genetic variants. And by putting a tier on it, you're just sort of bringing that up to the top to say, you know, to the people on your healthcare team, pay attention to these variants. They're very important for the patient care and treatment. And then the other part below, you know, the information about what particular change you have will be something like this. There'll be an interpretation. Usually it's written like a paragraph form. It might be a bullet point, really just saying, what is it about this variant that is important? So again, remember, this is a lung cancer. So, so in this particular paragraph, it's really saying that if you have a KRAS variant like this, you're not likely to respond very well to a TKI drug therapy, which is a type of therapy often given to lung cancer patients. So it might be a reason that you don't receive that kind of drug treatment. But there is some early evidence, if you read through that paragraph, some early evidence that patients, lung cancer patients with KRAS mutations might respond to other types of therapy. Okay, so this paragraph can also be very helpful if you have a look at it, just to see, you know, again, just to talk with your doctor about, okay, well, what decisions are being made based on this particular information. So I mentioned the tier. So tier 1, like I talked about, usually has an impact on the current treatment or the current diagnosis that you'll get. Tier 2, though, I definitely think they're important ones, or any variant that your physician is not acting on at this point. So whether they be tier 1 or tier 2. Because what often happens are these are variants that we know might be important because there's early research out there, or other drug development is going on that we might know about. And so these might actually impact on your eligibility for clinical trials. So that's also a very important thing to talk about with your oncologist. If there is, you know, do any of your test results, anything about your cancer, give you the opportunity to participate in a clinical trial if you're interested in that. I think that's an important part of being a cancer patient too, just to kind of be aware that the field changes so rapidly, and just have a way to have that talk with your physician if you're interested in clinical trials about how you might access that, and do these variants give you an eligibility to join some of those trials, because there is a lot of development in this field and for new drugs, and sometimes they're really honing in on patients with specific genetic variants and specific tumor types. I also wanted to just talk briefly about inherited cancers. So what I've been talking about to this point really are, again, the vast majority of adult onset cancers are acquired. So it's something that, we acquire mutations over our lifetime, and eventually in a particular tumor tissue, you'll have a tumor formed. So these adult onset acquired tumors are not inherited by your children typically. They don't affect any of your reproductive cells. They were not passed on. They were something that you acquired only in a very specific tumor tissue in your own body. However, some people have germline mutations that are present in all cells of their body, including in the egg and sperm, that can then be passed on to their children. And these are the families that often have cancer syndromes within the family, with multiple people affected, often with the same type of cancer or some related types of cancer. So for example, breast and ovarian cancer. And so then the risk of passing it on to your children, not all of your children will inherit it, but there definitely is a risk that your children will inherit your mutations. So even though the germline part is a small fraction of adult onset cancers, it's very important to find them, because you want to have those children who might be at risk undergo the right type of screening. The acquired and the inherited cancers are often due to mutations in different genes. So for example, lung cancer has a very small inherited component because the genes that are often in acquired lung cancer don't really have an inherited we don't really see that those are inherited mutations. But something like breast and ovarian cancer has a much higher rate of being inherited. And so some of the genes that we're looking at in the tumor tissue actually relate over to the inherited side. And so, like, as a patient, how do you know what you're getting? Definitely, again, just talk to your oncologist, but just even if you've had testing and you're thinking back about it, the sort of thing I've been talking about has been the somatic tumor tissue testing. So acquired where you're just looking at variants that are specific to your tumor tissue, not inherited. So these are where, you're getting samples taken through biopsy or through surgery, and those are being tested for the treatment options. So again, typically ordered by your surgeon, your medical oncologist, and then reported through pathology. If you're having germline gene testing, this would be done on a blood sample. It has historically been ordered by medical geneticists, often assisted with genetic counselors, but it's becoming more common that oncologists are also starting to order this too, sometimes, with a referral to medical genetics if you end up having a positive variant. There should be happening at this point some discussion with your clinician. They're telling you, we're looking to see if there's a family risk. It might impact on your family. We'll follow up depending on what we see, just so that you have an option. It's not everyone that would want that, but of course, with any test you're getting, that you have the option to say yes or no to that. And of course, that relates to any of the tests I've mentioned, but it's particularly, critical here that you depending on the point you're at in your cancer journey, you may or may not be ready to know about that. And then just kind of getting to the end of my slides, I just wanted to highlight that, each cancer has a specific set of genes and tests that are useful. So we really try to tailor the gene list that we're doing. This is showing you 4 different types of cancers and some of the common genes that we test. Not an extensive list, but just to point out that we really try to tailor those genes to the cancer type and to the known drug treatments or other prognostic information that are useful in that particular type. I haven't talked too much. I talked mostly about solid tumor, but of course, leukemia lymphoma has a really big genetic component too. We do a lot of testing for that. Those tend to be the cancers that have a lot more of the chromosome structure, changes in number of chromosomes, changes in structure. So we do a lot of just looking at straight chromosomes for that through karyotype. But although with the amount of actual sequencing of DNA is also increasing. So thinking again about breast cancer and this whole inherited part. So of course, you may have heard of the BRCA genes. There's BRCA1 and BRCA2. So sometimes if we've tested the breast cancer or ovarian cancer tumor tissue and we find a mutation in BRCA1 or BRCA2, that may also be a reason for your oncologist to refer you to medical genetics, to a genetic counselor, or again, they may order the tests themselves to look for the inherited component to see if it is, to test blood to see if it is inherited. We can't tell from testing tumor tissue if a variant is inherited or not. So there should always be, if something is positive and potentially concerning, there should be a follow-up test in blood. And as I said, that wouldn't necessarily be the same across all cancers. So for example, in lung cancer, EGFR has a low familial risk, so you may not have any discussion about that depending on what you see in your particular type of cancer. It's only for the cancers that have a higher inherited risk. Okay, so just in my last two slides, I just wanted to sort of give like some practical thoughts. So what do you what to ask your doctor? So I think first of all, just feeling comfortable that you understand your results. So what do these results mean for my type of cancer, and how the impact on treatment? How does it affect my treatment options? Do these changes make my cancer more or less responsive to certain treatment? And again, as I mentioned, if you're interested in clinical trials, are there trials that are a good match based on my genetic results and my tumor type? As I talked about with the inherited part, are there any genetic changes that might affect my family members? For a lot of cancers, the answer for that will be no, but it is important to keep that in mind and follow up on that if it is something that is relevant to your tumor type. And also, to keep in mind, just as I mentioned, the field is very fast moving. When should we look at this again and talk more as the new research develops? And just a couple of practical tips for managing your test results. I know personally, it's really hard to keep track of all the stuff that is happening at any one point as you're getting treated for cancer. A lot of things, a lot of appointments, and a lot of records coming at you. If you're able to access your patient chart electronically, that can help. That whenever you don't have to think about it. Whenever you need to, you can log in and have a look. But sometimes I personally found this very helpful. If there was some critical, and this relates to everything, not just reports, but if there's some critical information that you actually want a copy of when you're visiting your oncologist, they can always print it for you and just give it to you, and then you can write notes on it or whatever it might be. And sometimes I think having those records, and especially something with handwritten notes personally, also helps you think about how new treatments or research might impact as time goes on. So you have a record of what you discussed a year ago, and you can go back and think about that again later on. Certainly, I hope that this has helped you feel a little more empowered to talk about genetic findings with your medical team. And also, maybe to think about when additional testing or second opinions might be beneficial. Of course, you have a lot of interaction with the healthcare system as a cancer patient. And, sometimes you might think you need something more, or you want another opinion, and that's always an option for you too. And then, thank you. This is just my final slide. I'm just putting up here again those two resources that I had mentioned before, just so that you have them. I don't know if we can leave them up during the questions, but thank you very much. I'm very happy to have the opportunity to present today. Thank you.